Hello, everyone. I hope that you are staying safe during this pandemic. I wanted to provide you with a brief update of some thoughts that I've been having regarding treatment, infection control, and transportation of COVID-19 patients. And I think I also need to provide some minor corrections and modifications to some of my previous recommendations on the podcast that I recently released on COVID-19. This podcast will be a grab bag of sorts. My thoughts and recommendations are changing on almost a daily basis. Usually when I create show notes, I use Google Docs. Ryan and I will, we use the same Google Drive and we'll share with each other and we'll just compile our thoughts and then we'll compile a list of references and we'll comment on those references and we'll work it out together. But now I'm using Google Keep, so that can sort of show you how often things are changing. And just a forewarning, my thoughts may change tomorrow because I am receiving input from a lot of people. I'm following a lot of people at the forefront of this. I'm not really at the forefront. I am just learning from people much smarter than I am, and I'm digesting what they're saying, and then I'm kind of thinking about whether or not that would work in the pre-hospital field. So again, I am not an expert, and that is the main reason I'm putting this information out there. It hasn't been vetted. Now, I have looked at some references, but a lot of what I'm talking about hasn't been thoroughly vetted, and there's not great consensus on it. So I'm depending on you to vet it for me because my thoughts could change tomorrow. If you do have any recommendations, if you're doing something differently, please comment. I prefer that you comment on Twitter or Facebook because I think that it would be more visible and more people would see it. All right. So in the previous podcast, I spoke about open versus closed CPAP systems. To clarify, it is unlikely that a CPAP system could be truly, completely closed. Even if it's not vented to the room, because there's always a potential for a leak. Now, remember, we talked about vented versus non-vented. So if you have a CPAP system that dumps the exhalation directly to the room, then that is a vented system. So that is the furthest from closed that you can get. And if you're an EMS provider, there's a good chance that your disposable CPAP systems do dump the exhalation directly to the atmosphere or the room without being filtered, and there's also a good chance that there's no way that you could filter it. So you do need to check with your administration, or if you're an administrator, you need to look, because I do believe that they have, and someone told me that they do sell disposable CPAP systems that are not vented. But I do think that if you have the patient on a non-vented CPAP with a perfect seal and an expiratory viral filter, then I would consider that mostly a closed system. Now, I'm being very loose with my terminology here, okay? And I do think that that would potentially pose less risk to healthcare providers than either a high-flow nasal cannula or a nebulizer mask or nebulizer pipe. Although with a pipe, you could theoretically put an expiratory filter on a neb pipe. And then if the patient can only breathe in and out through that pipe only, then the majority of their expiratory breaths could be filtered. But that's a big if, and we're depending on the patient to not actually remove the pipe and then expire, which that is not usually the case. But I do think that if you must deliver a neb as opposed to a meter-dosed inhaler, then inline through a CPAP system described above, non-vented through a viral filter, is probably the best option. I would recommend, and this is a new thought of mine, that if you determine that the patient absolutely needs a neb and you don't have meter dose inhalers, or they absolutely need CPAP or BiPAP, that you place. All right, so what you need to do when you're placing this on the patient is you put the viral filter on the mask first. You don't connect it to the circuit because you want the patient to still be able to breathe. But you place the viral filter on the mask first, and then you place the mask on the patient before turning on the CPAP or BiPAP. Normally, I would tell providers to turn on the device first and ensure that air is flowing, and then place it on the patient. But if you do that, your system will be pushing air out constantly and possibly blowing the shedded virus around. Now, you can't do this. You can't connect it to the circuit or your oxygen source, depending on the configuration. But you absolutely can't really connect it to a circuit because that's going to severely limit the patient's ability to inhale and exhale. So you need to just do the mask first with a filter attached to that. So you can kind of stand back and then have someone approach the patient and then put the mask on their face. But you should have your CPAP or BiPAP system ready so that the amount of time that it takes between you placing that mask and getting oxygen going is as little as possible. So this should be performed quickly. Now, in the last podcast, I made a mistake when I said that Hamilton recommends 3 filters on the T1. They do only recommend 2 filters, and both of those filters should attach directly on the ventilator to protect the inspiratory and expiratory valves. Now, this is not business as usual. All right, so if you have a mechanical ventilator, you need to check with your manufacturer and see what filtering setup they recommend. You do want to protect the ventilator, but you also want to protect your providers. So that means that you need to ensure that the expiratory gas passes through the filter before going to the room. Now, we did locally consider adding a third filter on the circuit itself to protect the flow sensor, but there's likely going to be a shortage of vent filters soon, if not already. I've had a few people say or ask us where they could get filters. In the last podcast, I recommend using a blind insertion airway device such as an iGel or King Airway instead of an endotracheal tube, and I still do. If the intubation goes perfectly and you don't have to suction and you have VL so you can intubate further away than you do with DL, then that's great. But the chances are that it's not going to go that smoothly. They rarely do. And I don't know anybody who has a very smooth intubation every single time. But if they don't go smoothly, then you'll have to be down by the patient's mouth for longer than you should. And if you're like most EMS agencies in my state, you won't have RSI. So it's likely that the patient is likely still spontaneously breathing, either that or someone is performing CPR, pushing on the chest and forcing air out. So if you decide that this is a patient that you choose to not intubate and place a supraglottic airway device, then I recommend that you preload the viral filter onto the device. Now, that way, as soon as you place the device, you've got the filter on, and if the patient's spontaneously breathing or if CPR is being performed, then the gas will be filtered. Now, of course, air can still leak from around the mouth, but you're not going to have to be right next to it, and after you place the airway, you could then place some sort of barrier over the patient now that you have secured the airway. If you need to ventilate with a BVM, I'm talking before you place the airway, you want to pre-oxygenate the patient, then I believe that you can still do so. There is a lot going around social media about how to manage a patient's airway for pre-oxygenation. But I think if you are going to perform BVM ventilation, then you need to have all of your equipment pre-assembled. That means when you get in and check your equipment off, go ahead and put that viral filter on the ET tube. We go BVM, end-tidal CO2, viral filter. So have that ready to go. This is also a 2-person technique, meaning one provider's job is to only hold the mask onto the face and ensure a perfect seal and that there's absolutely no air leak. The other person's job is to squeeze the BVM. There's a lot of debate on whether or not we should even squeeze the BVM and should instead just place a CPAP mask and with straps on the patient, add a nasal cannula underneath the CPAP mask to ensure that a constant supply of oxygen and PEEP. Because let me back up. If you just strap a face mask onto the patient and turn the oxygen on the BVM up to flush rate, then you're still getting minimal air through to the patient unless they're spontaneously breathing and can actuate that duckbill valve. So to me, that seems like a lot of additional steps, and you're placing a nasal cannula under it, which is not likely to affect the seal, but there's a chance that it could, and there are ways that you can make this work without using a nasal cannula under it, but we're getting into the weeds a little bit. That seems like a lot of additional steps and increases the chances for making a mistake, when I think it's probably perfectly appropriate to dedicate a person to holding the seal and ensuring there's no leak and having another provider gently squeeze the BVM. Now, the general premise is that this system provides basically CPAP to the patient that you want to pre-oxygenate before you intubate. But it's a matter of consensus, and I think currently the data is showing us that you can squeeze the BVM if you are pre-oxygenating the patient in preparation for intubation. You can gently squeeze the BVM, and that is unlikely to increase the risk of gastric insufflation and subsequent aspiration. So, in EMS, we work with what we have, and I think that what we have is fine. So if a patient is not in need of BVM ventilation or CPAP, then you can simply place a nasal cannula on the patient. You could probably turn it up to slightly higher than normal flow rates and place a surgical mask over that. If you think the patient needs a non-rebreather, then you could try to place a surgical mask over that, but I'm not sure how well it works. Our ultimate goal, however, is to provide equally beneficial treatment without imposing a great risk to us, the healthcare workers. So if the patient really needs a neb, why not just use a meter dose inhaler? Well, there's currently a shortage of MDIs, but many patients that you would typically give a neb to probably have their own MDI. So just write a protocol for that so that we are still reducing our risk and can use MDIs for patients that already have them. But I would also write the protocol so that you can purchase and give your folks the ability to administer MDIs to patients who have influenza-like symptoms. But leave it sufficiently vague because you may need to order a mix of generic or brand-named MDIs because there is probably an ongoing shortage. Now, I do need to specify that you should use a spacer. Now, it's debatable as to whether or not you can reuse an MDI from patient to patient. Some hospitals do have common canister policies, and we have looked into this very thoroughly without really making a decision yet. But some hospitals do have common canister policies, and they use spacers between the MDI and the patient, and they adhere to strict infection control practices. Now, if you ask some people, they would say no, MDI should absolutely be discarded after use and that they're just single patient use. Other peoples would say that the risk is extremely small if you use a spacer and you perform stringent disinfection after using the MDI. We are also looking into valves. They do have one-way valves that you can add to the spacer that would allow the inhalation of the medication, but when the patient expires, it closes that off. And that is potentially one way to reduce the risk. There is some literature out there saying that, if you're a facility that has really stringent infection control policies and they're adhered to, then the risk is very minimal. The reason why this is a concern is it wouldn't be a concern if we could get MDIs or if there was not a shortage. And it also wouldn't be a concern if there was no risk to us as healthcare workers, because we could continue business as usual with giving breathing treatments. But now there's a shortage and there's a risk to us. So I am curious if any of you out there have a lot of experience with MDIs, if you're a respiratory therapist or a physician, or your service uses MDIs. Do you only use it on one patient, or do you have a common canister policy? If you do, I would like to see it and I would like to talk to you. So please send me an email. But in addition to the MDI protocol, you should add in there or give your providers the ability to give other bronchodilators early, such as IM epi or IV magnesium. Reverting back to CPAP, I did find some disposable CPAP hoods on the intersurgical website that completely encompass the patient and that can be driven by a Venturi type system off of your existing oxygen connections and regulators within the ambulance. These are pretty common in Italy, and if you watch some of the videos of them treating patients with COVID-19, they use these a lot. It is unclear to me from looking at the website if the expiratory valve on these systems is filtered or if it can be filtered, but this still might be a better option than using CPAP and potentially having a leaky mask spraying aerosols everywhere. I have reached out to the company to see if the expiratory valve can accommodate a filter, and I am waiting on a response from them. And if you know anything about these devices, please let me know. And again, this is bleeding edge type stuff. We're all trying to be nimble and work with what we have. So I want you to, respond to this podcast and my recommendations in kind, knowing that nothing is written in stone. And if you think something that I said was grossly wrong, or if you have a better way of doing it, please, I beg of you to let me know and provide some recommendations. So that's all for now. Thanks for tuning in. Bye.